All right. So welcome to this session on the Housing First philosophy. We're so excited to be able to be here with you and share with you. Want to give you a couple of words of introduction about who we are, where we're coming from, why we think we can talk to you about this content today. So my name is Ryan Villagran. I use they and them pronouns. I'm a training specialist with a program called Housing First University. So HFU, as we call it, is the training and technical assistance program operating out of a nonprofit called Pathways to Housing PA. So Pathways is an organization who's focused on ending chronic homelessness here in the Philadelphia area. We have been doing this work in Philly since 2008, and we use high fidelity housing first. And what I mean by that is we use the Pathways to Housing model as it was originally envisioned in New York City in 92. And we'll talk a little bit about that history as we go today. Um, we've had a ton of success using Housing First. We're currently housing close to 600 folks in a scattered site way throughout Philadelphia, and have had a ton of success with housing retention over that time. And so folks have reached out to us asking, how do you do that? What does Housing First look like in your community? How are you using harm reduction in that space? And what other practices are you using to make it work? So in 2019, we started Housing First University to be able to share out some of that good work and talk about Housing First in an advocacy-oriented way. My background is in mental health and substance use services predominantly, and I've also worked in a university setting and done some other training along the way. I think enough about me. I want to kick it over to my co-presenter, Caitlin, to introduce herself and her background, and then I'll take us through some quick housekeeping.
Hi, I'm Caitlin Mobley. I'm the Director of Outreach at Pathways to Housing PA. That's my current role, is helping people get into our program, but I've also had the role of assistant team leader and team leader. So I've seen a few different versions of how we do the work at Pathways. I've been in the Housing First model my whole social work career. I previously worked in Brooklyn before I was in Philadelphia.
Longtime Housing First practitioner. We're
Yeah.
both social workers, by the way, so heads up, shout out any social workers in the room. Um, Here's some quick housekeeping we wanted to share with you. We're just inviting folks to be present with us. 2 hours, I think, can feel like a long time, especially on a Monday when your work is piling up. I think, but if you're able to kind of shut off your Outlook and flip over your phone for these 2 hours, I think we'll have a better dialogue, a better exchange today. And in that vein, we're welcoming questions and comments throughout. We do have some dedicated Q&A time at the end, but I tend to be a long talker. And so I would much rather you get your questions, get your comments in, and we will address them as we go. So the chat is open. We are able to offer CE credit for social workers today. So if that's you, and if you want CE credit, stay the whole time, participate in our discussions, and make sure your camera's on so we can tell that you're there. And then you'll let us know you're looking for that credit using our course evaluation form at the end. So we'll drop a link to a Google survey right at the end. Let us know what you thought about the training. Let us know that you need CE credit. And even if you don't need that credit, we really appreciate feedback. We read all of that feedback and really take it to heart. We are going to take a short break in the training, like just a chance to shake it out, get some coffee, and start fresh again on the other half. And don't feel like you need to kind of furiously scribble down notes or take screenshots. We are going to make the recording available as well as the slide. So that's coming your way before the end of today. A note on accommodations. We do ask for accommodation requests on that Zoom registration form that you completed. We've attempted to meet those requests. We do have closed captioning enabled. So if that's helpful for you, you can click the show captions button. That'll get you the auto transcript. We are going to attempt to read questions and comments from the chat aloud, if that's helpful for anyone. We've tried to provide high contrast text and backgrounds in our visuals today. And if there's anything else that we can do to help your learning, facilitate your learning today, please send me a private message and I'll see what I can do as we go. All right, jumping right in. Here is our agenda. We're going to spend a little bit of time talking about the history of the Housing First model, where it came from, how long it's been around, how it's worked. We'll talk a little bit about why Housing First is needed. There are certainly many ways to provide services to folks experiencing unsheltered homelessness. We see this as one tool in the tool belt for our community, and it has certainly been an effective tool here for us. but we want to talk about why and who specifically can benefit from this model. We want to talk about the 5 key principles to housing first. You'll hear me talk a lot about the way that everybody's doing housing first right now, but fewer are actually doing housing first right now. And so I want to make that distinction and like let us understand, are you really doing housing first, and how do you know? We'll talk about some benefits and challenges of the model. We'll compare it to some other service model kind of ways that have been out there. We'll talk about what it looks like to initiate services in a housing first model. And then we'll talk about the way that we do bring in some other evidence-based practices into the practice of housing first. And then hopefully we do have some time for Q&A. In terms of learning objectives today, we want you to be able to get these 3 things out of the session today. We want you to be able to recognize barriers to housing stability for folks with disabilities. We want you to be able to identify the 5 key principles of housing first. Knowing what they are at a minimum and being able to kind of talk about them would be great. Being able to explain the benefits of housing first versus traditional recovery-based housing models is also on deck today. All right, let me get you engaged a little bit here. I want to do a quick temperature check, not using a show of hands, but using the poll that I'm going to launch now. Let us know about your level of experience with housing first. Are you somebody who knows a lot about housing first? Are you somebody with some experience or knowledge with housing first? Or are you a person who knows very little about housing first? This is an anonymous poll, so feel free to answer honestly. I see the responses still trickling in. Keep it coming. All right, it's starting to slow down. Let me give you 10 more seconds. Okay, closing the poll. Here we go. So with us today, it looks like we have around 30% of folks who know very little about Housing First, a little less than a third. That's amazing. I'm so glad that you're here. I'm so glad to get a chance to share more about Housing First. I think if you're very unfamiliar with Housing First, um, and if you're anything like me, it sort of blew my mind when I first learned about it and the potential for it for solving a pretty big challenge for folks. Looks like we got about 41% of people right in the middle who have some experience or knowledge of housing first. Welcome. I'm so glad to have you here. Hope you can learn something today, and I think you will. But if not, I hope you can share a little bit about what you know with us. And then lastly, 30% of folks who know a lot about housing first. These are the experts in the room. We're so thrilled to have you two. And again, welcoming your contributions to the conversation. If you know something that we are not sharing, put it in the chat. Raise your hand. Let's hear from you. All right, so let me keep us moving now. Want to do a little bit of an intro to housing first. And the way I like to start this is to really dive in quickly into this distinction between high fidelity housing first and maybe a lower barrier housing first approach. Okay, so the way we'll sometimes make that distinction is by talking about capital H, capital F. If you read any printed materials from Pathways, we do high fidelity housing first. And so you'll always see us use the capital H, capital F when we talk about housing first, right? So it's an evidence-based program model. There are, in fact, 30 years of research behind this model. And what it's doing is it's assisting folks experiencing chronic homelessness and who are living with severe mental illness and or substance use disorders. And you'll know you're doing high fidelity housing first because it has these 38 distinct fidelity measures that programs are kind of trying to measure up against. Do we do this? Yes, no, sometimes. Do we do this? Yes, no, sometimes. So we'll talk about what some of those are. You'll also know you're doing high fidelity housing first or closer to it if you're implementing ACT teams or ICM teams. And so ACT services, assertive community treatment teams, are kind of the highest level of community-based mental health and substance use care out in the world, right? Higher level of service than that is usually some form of like inpatient type of care. And it's permanent supportive housing, okay? So that is a very small nutshell of high fidelity housing first. I want to show you the lowercase h, lowercase f housing first. I think this is what most people are referring to when they talk about housing first, because most programs out in the United States are not doing kind of the pathways to housing model. I think what they're doing is something like this, a low barrier housing approach. We are using the 5 key principles, and we'll talk about what those are in a little bit. And it boils down to this basic idea, trying to meet somebody's basic needs first and then provide wraparound supports. In other words, not asking people to get well in any specific way before coming into housing. We're saying, hey, here's your housing. Now let's figure out what services you need. That's housing first in a nutshell, right? So a little bit more about the history and about what it is. As I said, it's an evidence-based program model. It's specifically focused on people experiencing chronic homelessness. I do think this is one space where when I think about other program models like rapid rehousing or transitional housing programs, um, those programs I do think sometimes struggle to serve people who have experienced chronic homelessness. In other words, they've been on the street long term, have not been in their own unit in quite a long time. And when they get into a unit with a time limited duration, they can sometimes struggle to be successful in that time period, right? Let's say we're going to pay your rent for 2 years. At the end of that 2 years, some of the folks who have experienced chronic homelessness have not skilled up enough, has not received enough support, have not been able to kind of like meet the objectives to be able to be independent without program level support. Housing First also offers an immediate rental subsidy, right? So when Caitlin goes and meets people on the street, sometimes that day they're willing to accept coming inside. Sometimes not. Sometimes it takes a little longer. But Caitlin is saying to folks, hey, we have a subsidy for you. Come on inside. And it's giving it to them right there for permanent supportive housing, right? With no endpoint. There are no preconditions or barriers to this. And specifically, what we mean there is we're serving folks with substance use disorders and mental health challenges. We are not asking folks to step into treatment beforehand of any kind. We're not asking them to kind of run around the world trying to collect documentation to prove their financial status or any other sort of status, right? No preconditions or barriers means, hey, we know about you already. We know you've been experiencing chronic homelessness because our HMIS system is telling us this. Come on inside, right? There's also no predetermined endpoint. Now, that doesn't mean folks never leave a Housing First program. And in recent years, we've seen some success with an alumni program that we have where folks really don't need us anymore. We've been able to help them get on their feet over the course of some amount of time. We've done that wraparound support. We've helped them connect to community-based supports, whether that's primary care or mental health supports or whatever. And they simply don't need us anymore. They don't need a case manager coming in and knocking on the door every couple of weeks saying, hey, what's going on? What can we do for you? Right. And so those are huge successes. We've been able to flip them to housing choice vouchers and said goodbye. We're still here if they want to check in. We can still be available, but we're not serving them in that way anymore. And so those are a huge success. But not everybody's going to reach that point, right? And so there is no predetermined endpoint. It's not 5 years from now. It's not 10 years from now. Many folks will live out the remainder of their days in our care. And then it does include wraparound supports, right? And so, like, as I mentioned, we do high fidelity housing first. And so we're using an ACT team. So a team of interdisciplinary professionals, maybe 8 to 10 folks on that team in a variety of roles who are supporting folks in this kind of team-based model. In other words, it's a shared caseload. So it's not the folks on my caseload or Caitlin's caseload. It's on our caseload together. Caitlin may go see somebody today. I may go see somebody next week. And so it's a lot of communication to kind of make sure that we're not losing people through the cracks. Any questions so far? I know I'm going through this a little quickly. Let me just pause here. How are we doing, folks? Any questions, comments, or thoughts so far? Okay. Feel free to raise your little Zoom hand if you want to get a word in. But again, feel free also to use the chat. Okay. In terms of the history, the Pathways to Housing model was founded by a clinical psychologist named Samson Barris. That's his photo there on the screen, in New York City in 1992. Um, it's been around a long time. And so anytime you hear somebody talking about kind of a new or radical approach and it's housing first, that I think is missing quite a long history of this work. So he started this in 1992. The organization was called Pathways Housing First. And after a number of years, it was added to SAMHSA's evidence-based registry. So it is an evidence-based practice, meaning there's a ton of research behind it that's been validated, and it's been replicated. In fact, it's been replicated in over 150 US cities and in many countries. The cities that I'm hearing about most recently in terms of success with their Housing First programs are places like Houston, places like Denver. Those are the ones that I think are getting the most buzz whenever I go to conferences and like who's doing this well right now. Of course, we've also got places like Finland, whose national strategy includes Housing First. And in fact, they are a place that reports having functional zero homelessness, right? In other words, folks may become homeless, but they're not unsheltered for any like length of time that is significant, right? So there, people do arrive in homelessness, but the supports are able to get them back on their feet, and they use the Housing First model to kind of arrive at that point. As I mentioned, Pathways to Housing PA, that's us, has been operating in Philly since 2008. We, in fact, were an offshoot of that original Pathways to Housing program. And in I think 2013, we kind of broke off and became our own fiscal entity. But there are also some other pathways out there in the world. There's a Pathways Vermont and a Pathways DC. DC looks a lot more similar to our program in terms of urban population and setting, whereas Vermont is more rural, and so it can look a little different. All right. Um, I guess one other thing I'll say about Pathways is Pathways PA was the first program that we're aware of in the country to apply the Housing First model to folks with opioid use disorder as a primary diagnosis in a scattered site program. If you know anything about Philadelphia, we are one of the kind of hotspots on the East Coast for opioid use disorder. Often the things that we see among the drug using population here are things that other places will see in the coming months and years. In other words, it ends up being kind of a front line in terms of what drugs are happening, what's the overdose crisis look like, how are we getting people off the streets. I want to start to kind of bring you folks into the conversation a little bit more. That's my kind of like history and boring, dry stuff. And so I'd like for folks to kind of think about who are people who we would call homeless, right? And if you're a longtime practitioner or you've been in the field serving folks experiencing homeless for a while, I'll ask you to take off your trauma-informed care hat, take off your like social worker hats, and just start to type into the chat some of the kind of general perceptions about people who are experiencing homelessness. Who are these people? What are they like typically? What are the stereotypes we have about these folks? And be brave. It's okay to write something that you don't agree with. Yeah, I see the responses starting to come in now. Maybe people we would describe as druggies or dirty, or there's this element of like laziness there, right? In other words, I don't want to work. Yeah, people have been called bums. They're all on drugs and drink. Yeah, a common stereotype there. Addiction, they're unemployed. Yep, they're lazy. They don't want to work. Yeah, some of these same tropes are coming up over and over again, right? They're lazy or they're addicted. Yep. Thanks for sharing this even more specific comment, Katie. They can't be trusted with money. Interesting, right? So something about the way they manage money means we can't even give these folks money because they're going to squander it, right? Or something like that. People who don't want to work, people who don't care, they don't want services or help. Wow, they're out there living very rough and they simply don't want any help or services. They don't have family. They don't want to be a part of society. That's so interesting. Yeah, great set of stereotypes there. Folks who are looking for a handout. Oh, Mario, thanks for sharing this one. This kind of perception of danger out there, right? If you see somebody who is experiencing homelessness, they must be dangerous. I just like have to kind of like step out of this activity that we're doing right now and shake my head at that one because it's wild. I think it's the flip. Often the folks experiencing homelessness are feeling in danger quite a bit. They don't want to help themselves, not acclimated to living inside. In fact, I don't even know if I would call that a stereotype, Arrow. I think that in some cases, at least the folks we serve, that is quite true, depending on how long they've been unsheltered. They're mentally unstable, they're quote unquote crazy, and there's no motivation. Yeah. Thanks so much for sharing this. I know that that can be hard to kind of like tap into some of those stereotypes because as providers and as people who care about people experiencing unsheltered homelessness, like these are the advocacy kind of challenges. These are the things we're pushing against all the time, right? Um, but I think you're all right on the head, right? Like we have this idea that folks become homeless either because they're lazy or they're crazy. And of course, our broader society wants to kind of oversimplify the causes of homelessness by saying it's a personal choice. They don't want to be inside. They don't want help, right? But realistically, homelessness can be caused by so many things, right? Of course, we know it can be caused by some environmental factors. Perhaps you're aware that there is a housing affordability crisis out there in the world right now, right? There's a couple of reports that I like to check out from the National Low Income Housing Coalition, and who document that we're short affordable housing units by about over 7 million. It's almost 7.5 million affordable housing units that we simply don't have available for folks who need it most at the lower end of our income spectrums, right? So housing costs are rising now. I think we can even think about the impact of gentrification. One of the kind of key places where homelessness and drug use are intersecting here in Philadelphia is a neighborhood called Kensington. And the folks who work most closely from Pathways in that section, they call it a conspiracy theory, but I think they're right on, which is that they're starting to do sweeps of that area for folks experiencing homelessness in an effort to make that area more attractive to developers, right? Which is going to increase the costs of those areas and it's going to further push people out. Of course, it's not doing anything about the problem and kind of pushing people even further away. Oh, Mike, thanks for kind of reframing my comment there. I see it as 7.5 million people being paid not enough to live on. And in fact, you're right. In order to live in a kind of median one-bedroom apartment in the United States, when you're working full time at a minimum wage, it's not possible. A person working full time, or excuse me, a person working at minimum wage would have to work over 100 hours a week to afford that unit, right? So I think you're right on there, Mike. Other environmental factors, the removal of institutional supports. I think we continue to deal with deinstitutionalization, on its face, a positive thing. In fact, though, they're not having enough community-based supports to fill the gaps when people lose those institutional supports is a major issue. I'm even thinking of folks like aging out of the foster care system. Uh, there simply is no place for these folks to go in many cases, right? There are decreased job options out there, jobs that don't pay a living wage, as Mike mentioned. And of course, a history of racist and exclusionary housing policies. We are still dealing with the effects of redlining, in fact, in the United States. And these gentrification issues that we see are really overlaid there, right? Where you see a neighborhood that has traditionally been disinvested in becomes a hotspot for development and sort of pushes people even further out, right? There are, of course, individual factors as well, right? There are people that experience severe mental illness and are challenged by that. There are people that experience significant substance use, people with cognitive impairments, even chronic health conditions can push people over the edge into the experience of homelessness. People's trauma histories plays a factor there. I even think of folks returning from military service, right? Maybe they started using substances in their service, or they simply were not adequately prepared to kind of return to civilian life after living, I think, some horrors of like wartime warfare, military service, right? And then when I think about all those things, the experience of mental health or substance use or trauma histories, I saw somebody say earlier, let me see, let me pull it up, something about not having family supports. Sometimes that loss of family supports is around like family can't be the only support anymore and those bridges get burned. I see you unmuted, Caitlin. You want to add something?
A recent trend that we've seen with our referrals from the city have been elderly folks that their spouse has passed away and they can't support themselves without the spouse there. So that's another family factor that we've been seeing a trend of lately.
Yeah, and I assume those are folks who maybe had been living independently with their spouse for years and years and
Mhm.
years and years, right? Like these are not folks
Right.
who um, are like your traditional lazy or crazy type folks. These are folks who simply can't afford to live anymore without their spouse.
Yep.
So I think odds are that we all have people in our life who we know and love who have experienced some of the challenges that we've talked about among those environmental and individual factors, right? Um, and some of us are more equipped or have more privilege to sort of deal with those challenges, or our family can support us during those times. Saw a recent stat that around 49% of Americans are ill-equipped to cover a $400 emergency expense. So, in other words, around half of us in the United States are not going to be able to afford that emergency room visit cost and the things that come with it before kind of tipping over the edge of being unable to pay our bills, right? So, $400 can be the difference between housing stability and becoming unsheltered and living homeless, right? Let's talk a little bit then about who are the chronically homeless, because we know that these factors can affect many of us or all of us. Who are the chronically homeless? I'll pass it over to you, Caitlin.
So the chronically homeless are those who have been homeless for at least 1 year or who have experienced homelessness multiple times. In Philadelphia, we consider that 4 instances of homelessness across 3 years that equal 12 months. And this can also be, we have a system in Philly that the outreach workers document this, but it can also be self-reported in certain cases. These folks can often be considered not ready for housing because of unmanaged mental illness, substance use disorders, and or physical disabilities. It could be someone that you see on the street and you're like, I don't know if they could, you know, be in an apartment right now. But the reality is that with the right supports, they could be. Um, it can also be many people that have tried and failed in multiple programs. The Pathways to Housing specifically, we'll see folks that have come from other city housing programs that have more barriers. Some programs uh, will require sobriety, or they'll require that if you don't pay your rent, there's no buffer for that. Whereas we require people to pay a portion of their income towards rent if they have income. But say there's an issue 1 month, we can come up with payment plans for them that like 1 month or 2 month issue won't cause them to lose their housing with us. It can also be folks that have just been unsuccessfully engaged, for whatever reason, they haven't related to folks that have been offering services. So with our team model, we offer all different types of people. We have certified peer specialists, we have nurses, we have service coordinators with all different sorts of backgrounds to see who that person might relate to most that could help them get the services that they're looking for. Oops, I think I double clicked. Yeah, sorry. A way to look at housing readiness through a model could be Maslow's hierarchy of needs, which is a motivational theory in psychology that was proposed by Abraham Maslow in his 1943 paper, A Theory of Human Motivation. And it shows on a tier system what needs need to be met first in order for other needs to have room to be met. And the base level is physiological basic needs: food, water, warmth, rest. And that's what we're looking for with Pathways to Housing. If somebody has access to food, access to a house, they can start to work on these other needs that are more challenging to do when you don't have food, water, warmth, rest, such as security and safety, and then a belongingness, and intimate relationships, friends, an ability to have a social life, and then esteem needs, prestige, feelings of accomplishment. Oftentimes, when we see people housed with us for even just a few months, it's amazing how quickly they can start to address some of these other needs. We'll have folks that will be ready for employment much quicker than we thought. We offer some supported employment opportunities. And sometimes someone will be in an apartment for a month and they'll be like, okay, I feel like I can work now. I worked really recently and I'm ready to meet some of these needs, which can lead to esteem and just feeling like a member of the community in a new way. And then the final is self-fulfillment needs, achieving one's full potential, including creative activities. One of my favorite things to see at Pathways is when our participants feel like they have the time and capacity and like emotional availability to do creative stuff with us. We'll have folks that will read poems at events that we do, or we'll play music, or we'll just join for museum trips or doing arts and crafts classes. Like when somebody finally has the ability to have capacity for that in their life, it can be really rewarding for all involved.
Can I just say too, and we're going to make this contrast a little bit as we go, but the contrast between this kind of like bottom up, meet your needs and further needs will be able to be met. That in contrast with maybe what I would consider a more typical approach of asking people to kind of meet these other needs first, right? Get into treatment first and like all the self-esteem and stuff that kind of requires and engenders, do all of that stuff first and then you'll be ready for housing is the big contrast that we want to make here, right? I think people want those things that we want for them in a more treatment first type approach, but don't have, as Caitlin like so eloquently put it, the kind of emotional space to not be thinking about their survival needs, right? Their basic needs. And so when we can take care of those, people are naturally going to start to move up that hierarchy of needs. That's our perspective, at least.
Yeah, it's interesting. I also see in outreach a lot that somebody, say someone with opiate use disorder, will really want to go into treatment, but they're concerned that by going into treatment, they'll lose their spot in housing, or they won't be available to do what they need to do for housing. So that's another piece where we can have conversations about like what that really looks like. That no, if you go into treatment, we could, it's not a requirement, but we will make sure that we follow up with you so that as soon as you get out, have your housing need met. Or sometimes people will get housed and then immediately start to want to work on those things because they have the peace of mind of knowing that they have an apartment to come home to, and that they're not fearing that they'll go back to the street if they choose the treatment route. That's not our requirement, but I have seen that as a trend. Oh, there it goes. This is a quote from the executive director of Pathways Vermont, which I'll let you read on your own. But the main point of it is people have needs and some skills, but they haven't always been engaged in a way that works for them. Her analogy is, standing outside of a bakery and wanting to eat, having the money to eat, but not knowing how to go inside. So I love that frame of mind, because you can see someone on the street and be like, well, why don't they just bring themselves to the doctor? Why don't they just bring themselves into the hub? We have something called the Hub of Hope that helps people that are on the street meet some of their basic needs. And the answer is oftentimes they have the desire, but they're just not quite sure how to do it. And they need somebody that can meet them where they're at and speak to them about their concerns, speak to them about fears. We're working with folks that have a tremendous amount of trauma and that have oftentimes had the system, quote unquote, fail them, or they'll open up to somebody about their needs and then they'll be forced into something they don't necessarily want to do. So it's the trust building, it's the rapport building, it's the showing that will help you meet this exactly where you're at currently without forcing you to do something before you're ready. People don't become homeless because of moral deficiencies, as we talked about when everyone was listing all the stigma that can often be placed on folks with homelessness. People become homeless for all sorts of reasons, but they stay homeless because of the system failures. And it can be good to view our role as service providers in that. Our role is to help the system become more accessible to folks, but it's very intimidating. I frame it to folks that are new workers in outreach. I'm like, imagine that some random person just comes up to you on the street one day and says, hi, I'm here to give you housing. You'd be like, what? Like, are you really? It takes a level of relationship and rapport building.
And then also like contrasting that with maybe I've been in a shelter, it wasn't a safe environment for me, and the workers in the shelter have kind of tried to move me through a housing process, but then I screwed it up somehow.
Mm-hmm.
They caught me with some drug paraphernalia in the shelter, um, or I didn't come back in time for the curfew one day, and so it's all derailed. And so like somebody coming up to you on the street and saying, "Hey, here's some housing," feels a little bit too easy, I think, for folks or something, or it's just hard to have that trust, I think, immediately, given the experiences that they've already had in the system.
Yeah, I've heard people say to me, I've seen this before, like this didn't work for me before. And so explaining in very accessible terms, like how pathways to housing specifically might have differed from other programs that people have experienced. And making it very clear, I've learned I've had to make it very clear that we're not linked to like the hospital system, or that can be a fear that people have too, that we're just secretly trying to get them into mental health treatment that they do not care for at that time. So, I'm reading this comment. Magical thinking on part of. Sorry, you can't read the whole comment. Magical thinking on part of some of the homeless people that with housing or shelter your future is sad.
That's interesting, Mike.
Yeah, that well, yeah. Go ahead, Brian.
I think that is interesting, Mike. I don't know that I've heard that like expressed in that way, but from my perspective, your future can't be set without housing and shelter, right? Like I think that's what we've tried to demonstrate through the Maslow's hierarchy is that the future, like the possibilities for our future are really enormous. But without having a stable base, I think it's going to be really hard to achieve any future that you're going to want, right? And so our perspective is, okay, maybe you're not going to achieve, status as an astronaut, but like whatever you want to achieve has to start somewhere. And we think that place is housing and shelter.
You at least have the space to determine what you would like to work on. And then the service coordinators on the team and the nurse and the CPS and everyone can help. One of the hugest jobs that I found when I was a team leader is helping the staff understand, like, okay, someone tells you their goal is this thing that we all know they're not quite ready for yet. I had someone on a team once that said that his goal was to be a taxi driver because that's something he had done in the past, but where he was currently at, he was not in a place that he could drive a car. And so our job was to help him take this higher goal and to see the steps that could lead up to that eventual goal, or to reframe the goal. Like maybe he can no longer drive a car, but what could he do that is like similar to the amount of hours he used to work, but a different type of job. So helping someone take these like maybe lofty goals and help them figure out an accessible way to get there over a period of time. So taking care of ourselves is much more complicated when we don't have stable housing. That is the theme that I feel like we've been talking about over the past few slides. We all need a home to be safe and healthy and to thrive. And by providing permanent housing without a precondition, we can help people work on these things. And this is, I'm going to click through these examples of if you're on the street. Sorry, my slides are not wanting to click through for me. There we go. How if you were living on the street and say you want to go get your health taken care of, you go to the doctor, you get a prescription, but where do you store your medications? Do you have transportation to get to the pharmacy? Can you afford the copay? So you do the first step of going to the doctor, but then instantly there's all these barriers that you might not be sure how to navigate. And then you have a follow-up appointment, but do you have a calendar to remind you? Do you have a phone that can tell you the time, or a watch? Do you know how to reschedule if you miss it? Do you know how to get to the place? Do you even know where you'll be staying the night before so that you can get to the place easily for the next appointment? Do you have an alarm? And even if you do have a cell phone, where can you charge it? I meet people on the street sometimes that they're like, I have a cell phone, sometimes it's on. And it's on, like they can't always pay the bill, or they can't always find a place to charge it. So it can be a tool, but it's not a reliable tool. And if someone simply has an apartment, they have access to some of these things. They can have a calendar on the wall. They can have an outlet. They can have an alarm that wakes them up. We give people moving kits that include these things so that they can accomplish these goals. You can tell your team, I need help getting to this appointment. It's hard for me to navigate the bus on my own. And someone from your team can come and bring you to that appointment. So instantly, these barriers that someone on the street, you're like, why won't they just take care of their healthcare needs? Well, these are some of the reasons why. And just by simply having an apartment, they can begin to, this can become more accessible.
Yeah, thanks for walking us through that.
Mhm.
We think that kind of this long-term homelessness that we're just describing, this chronic homelessness in particular, also any homelessness, but really, I think you'll see that the housing first model shines with people who have been experiencing unsheltered homelessness for a long period of time. We think it's solvable. And we think that these kind of five key principles of housing first are the baseline, right? These are the foundation that we build a housing first type program through to meet these very challenges that we're describing. So we want to walk you through each of these five key principles. I'll just list them here. Um, what I said earlier, that how do we know we're doing housing first when everybody seems to be saying that they're doing housing first? I do think that these five key principles are like the core. Are they doing this, and this? And if they're not doing any of those things, maybe we need to look at whether they're actually a housing first program. Now, I also think that there is space and room and need for services that are not housing first services, right? A continuum of services makes a lot of sense. A rapid rehousing program makes a lot of sense. Transitional housing makes a lot of sense, but for a very specific need, a very specific set of needs, right? And so this kind of long-term chronic homelessness for people experiencing mental health challenges and substance use challenges, I think these key principles are like the foundation. So, immediate access to permanent housing with no housing readiness requirements, participant choice and self-determination, multiple pathways of recovery orientation, individualized and participant-driven supports, and social and community inclusion. We're going to dive into each of these now to kind of give you a little bit of a perspective about how we actualize these principles. I think there are many ways to actualize some of these principles, but we want to kind of just talk to each of them a little bit. So, Caitlin, talk us through this permanent access with no housing readiness requirements one.
Right. Sorry, there we go. Okay. Everyone deserves a safe and permanent place to live. The most basic way to view it is housing is a basic human right. Every single person is entitled to housing, and safety and shelter are a primary need that must be met. As far as housing readiness goes, everyone is ready for housing. We do see sometimes when I'm engaging with folks on the street, or teams are engaging with folks on the street, occasionally we'll see people that need a higher level of care than what we can offer. That might be someone with dementia, or someone with just who prefers a group setting, or for safety reasons for themselves, like being able to navigate an apartment, they would benefit from more of a group setting. However, they still are entitled to housing, and it's our responsibility at that point to help them find the version of housing that works for them if it's not our program. And that's oftentimes coordinating with the city and communication with the city that why this person doesn't quite meet our model and what we can do to help them still receive housing services.
Can I say that I think, I wonder if you agree with me about this, Caitlin, but I think other, when we sometimes do technical assistance with other organizations, this idea that like, oh, a person needs a higher level of care than we can provide, I think we're less quick to jump to that, or we have kind of very specific things in our mind about how we simply are not going to be able to support people. For example, people experiencing dementia, the program wasn't designed to support folks experiencing dementia, right? It's designed to support folks experiencing chronic homelessness, mental health challenges, and substance use disorder, right? And so there are some specific things, but in general, this idea that we're really wanting to screen people in, because we are sometimes the last stop in terms of like our housing continuum for folks. They've tried other housing programs and have not been successful. And I think sometimes we see programs saying they're not ready for housing. And so our knee-jerk response to that is, yes, they are. What supports do they need to be successful in this housing? Sometimes it is true that this level of support is not the right level of support, as Caitlin mentioned. But in general, we want to kind of like, let's say that yes, they're ready, and then figure out what to do next if it's not working, right? But that high level of support is going to be necessary to make that work.
Yes, that's a very good point, Ryan. I'm glad you elaborated on that more. It's rare that those occasions happen that someone needs a higher level of support, and we have multi-tiered steps to determine if that's the case, through psychiatry and through other factors. But yes, the mindset should be we are screening them in, and then when all else fails, if we're truly not the program for them, then we think about what the next step is. But thank you for elaborating on that. That's a good way to view it. Another factor is participant choice and self-determination. The biggest factor here is that we are person-centered. We meet the person where they are at. When I first meet someone on the street or when the teams first meet them on the street, I always make it very clear to them, we are here to help you with what you are ready for help with. We are not going to force you to do anything that you don't want to do. Sometimes people are ready to accept help in other areas in their life, access to medical care, getting around the community, access to food before they're ready to accept access to housing. And that's totally fine. Engagement can take a long time to get someone to decide when they're ready for housing services. We also give people choice of what neighborhood they want to be in. Their recovery path, I always make it very clear to people in the beginning, we take a harm reduction approach. If you're using any substances, that will not stop you from moving into an apartment. It won't keep you from keeping the apartment. You can be open with us about it. We won't force you into treatment. You can talk to us about your goals with it. And those goals may change and evolve over time. They're not linear. We'll meet you wherever you're at with that. And along with the person-centered piece, I do make it clear the things that are non-negotiable, which are that we must see you in your home 2 times a month, and that if you have income, 30% goes towards your rent. But outside of that, you tell us what you're looking for, and we will help you accomplish those goals at the pace that works for you. Another piece of that is the choice to take medication or not, too. Many programs require medication monitoring, or that you must meet with a psychiatrist. We require that someone meets with a psychiatrist for an initial eval upon entering the program, just to confirm their diagnosis for a program. But then it is up to them if they want to continue those services or not. Of course, sometimes we see situations where someone would really benefit from mental health care that's not yet ready to accept it. And that's when we work with them, rapport build, talk about the fears that they might have around it, what can make it more accessible, what they do want to accept. I once had a participant who was housed who had diabetes that was very not in range. Like his blood sugars were always extremely high. I'd come over sometimes and he would literally be like chugging maple syrup to try and self-regulate his blood sugar. He really needed medical attention over it, but he did not want to receive it. And after speaking with him for a while and really delving into it, he finally was able to say, it turns out he had stigma around needles and for insulin. And he thought that if he was using needles for insulin, that people would think that he was using drugs, and he didn't want his neighbors or people in the community to think that about him. And once he was able to share that, we were then able to help him receive care for the diabetes in a way that he didn't even have to really use needles, or he could use them in a very discreet way that others wouldn't know. So that's a good example of meeting him where he was at, and not assuming he just doesn't want to manage his diabetes, but having conversations around what the concerns are. Participants guide what services they want access to and when they want to start. That's the base mindset to have around this component.
I hope this doesn't come across as like too similar. I do think some of these like principles and the way we talk about them are very similar, like choice and self-determination at the center of everything. Here's another one. So multiple pathways of recovery orientation. I like to talk about harm reduction more on this slide, where, recovery is a pretty broad term these days in 2024. Wanting to kind of make a recovery accessible to folks that is not necessarily this all or nothing like abstinence focused recovery. Even here in Philadelphia, since around 2006, they have talked about like the mental health transformation in our system, where recovery is really being claimed by the mental health kind of service recipients and providers. And so this idea of redefining recovery, we're spending time kind of supporting folks in defining what recovery does look like for them. What are your goals? I see that you're, a drug user, and it looks like this amount, this frequently. Do you have any goals with that? Yeah, I'd like to cut back a little bit. Okay, that's a recovery that we can get behind and support, right? And so kind of not forcing an abstinence or treatment-focused approach on anyone. We make heavy use here of peer supports to kind of facilitate these conversation, right? So on each of our ACT teams, there is a certified peer specialist. There are also some folks with self-identified lived experience in other components of our service delivery model, but always having a CPS on the team to kind of facilitate these um, definitional conversations. What is recovery? What does it look like for you? How do you want your relationships to substances to be, or your relationship to mental health medication, and wanting to facilitate a broad range of options there. And so our teams have to be kind of well versed in harm reduction strategies, in having conversations that can feel uncomfortable, because it's not about us, right? Even our peer specialists who are so invested in the 12-step model, for example. We have a number of folks who spend a lot of their free time in NA and AA rooms, have to be well versed and comfortable in kind of speaking the harm reduction language to meet people where they're at. Yeah, and then just kind of this idea of focusing when we think about recovery, thinking about it in more holistic terms, right? What's recovery look like with respect to social, recreational, educational components of our lives, vocational? I think Caitlin's example of like a person wanting to get back to taxi driving represents kind of a marker in that person's recovery. Do I feel well enough in these various areas of my life that I could drive a taxi again? That's recovery, right? And so wanting to kind of be accepting of those broad definitions. The next one is individualized and participant-driven supports. This can be frustrating, I think, for program staff who have never worked in a housing first type program, not having a ton of standardization, not having, and in fact, like the housing first fidelity principles specify like a lack of some of these standardized procedures. For example, folks who have been on the street long term, we understand that maybe a third of folks that we bring in are are not going to be in that same apartment as time goes on. In other words, they're going to experience some failures along the way or some challenges in maintaining their housing. And so we'll rehouse folks. And when we rehouse folks, we know that the percentage of people that have to be rehoused again drops by half. In other words, people have learned some skills. We've supported them in that transition, and fewer folks are going to have to be rehoused again, right? What the housing first fidelity principles say is that there is no specified limit to how many times somebody can or should be rehoused. And I think you might see something like, okay, we'll rehouse you 3 times, and after that, we'll have to give somebody a chance, right? That's a standardization that the housing first model doesn't get behind because it's not individualized enough. What's going on for this person in this circumstance, and how can we support them best, right? And so again, that can be frustrating because the staff may say, we've tried 3 times already. Why does this person get a chance when there's somebody else? And we have to wrestle with that, right, on an ongoing way and discuss that as a team. And so there's no one size fits all, no sort of specific set of services that are going to be the right fit. The program is going to look different in a housing first model for me than it would for the next person down the line, right? I may choose to only access the primary care services on site and not any of the mental health or behavioral health supports. Another person may choose to want to do Suboxone only and never see the doc for their primary medical care needs or never see a therapist. Okay, all of that is acceptable. And we're wanting to meet people where they're at. And because it is participant driven, we want it also to be on demand. So if I have decided I only want to see primary care, but 2 weeks from now, I'm ready to see you about Suboxone, we want to jump into action there. So we have to have a broad range of services available, but then make them available on demand. No, I'm sorry, you can't do that service. You already said no. That's not a conversation we want to be having with folks, right? If you're ready now for some set of services, we want it to be available to you. And I think this echoes a lot of what we've talked about on these key principles so far, but choice in all areas of programming, whether that be choice in their housing, in their health, mental health, substance use supports, their life skills supports that we can help them manage, choice in all areas. And then the fifth and final key principle, thanks for bearing with me. I know it can feel kind of very like theoretical and academic to go through these principles, but this is one that I think gets lost sometimes in traditional homelessness services, social and community inclusion. I say it gets lost because we as providers and also the folks that we're serving can be very focused on like those survival needs, right? I'm just trying to have enough like food in my belly on a day-to-day basis or have a warm place to sleep on a day-to-day basis, right? And sometimes the social and community inclusion piece that we think is so critical to living a life with meaning gets lost, right? And so we're pretty big on community inclusion here at Pathways. In particular, we think it's a thing that works to combat the stigmatization of people experiencing homelessness and the isolation that can come. One interesting thing that we see, I'm sure you all have seen this too, is when people become housed for the first time in a long time, that can be an uncomfortable experience for them, right? And so we have plenty of stories of folks who sleep on the floor for some length of time, even though there's a bed right there in their unit, right? Or feel a sense of loneliness when they have removed themselves or been removed from all the people that had their back while they were sleeping on the street, right? There is a sense of community there. And in some ways, this transition inside can break that, right? And so wanting to help people tap into whether some of those old familiar communities or some new communities and tap into like what it means to be a whole person with a social life, right? And so we do things with our community inclusion department like restaurant club, an opportunity to go to a restaurant that you've never been to before and be served a meal with a group of your friends is an experience that many people who are living in homelessness do not have access to, right? Um, Providing folks neighborhood resource guides when they first move in. Here's the laundromat. Here's where you go for a snack when you want to get out of the house. Kind of helping people navigate their new community that they're living in, if it is a new community. Um, yeah, doing things like lunch clubs and mani-pedis and going to the movies and gardening club. These are all components of our community inclusion department. Helping people kind of get reintegrated into community, and helping fill their days with meaningful social activity, whether that be cultural, spiritual, civic engagement. Caitlin had mentioned the employment supports that we offer and other versions of recreation, even including budgeting and things that are more sort of like typical for a person living in an apartment, and not forgetting the importance of relationships. So those are the 5 key principles. Um, I think, as I'll say, I'll restate this. I think without those 5 key principles, I don't know that a program is doing Housing First without those. Um, Maybe they're doing some version of like low barrier supports, or they're borrowing from Housing First approaches, but I want to kind of emphasize the importance of those things. Um, we keep talking about the fidelity measures, Housing First fidelity. And so the fidelity measures are a way that we measure Housing First, right? And so the Housing First, high fidelity Housing First requires adherence to these 38 individual principles, and they're across 5 different categories. It's housing choice and structure. It's the separation of housing and services. In other words, it's not our case managers who are also harassing people for their rent. Having a separation between having a specific housing department and a clinical department. Um, the service philosophy that we approach things with, the array of services that we have, and the structure of the program. These are all things sort of defined by the high fidelity, the fidelity measures, excuse me. We have a tip sheet that we're going to share with you once we send out our email of our materials, and it's the actual fidelity measures. And so you can see, how do you measure up against Housing First? I would love it if folks had the idea to sort of like informally look at their own program and say, yes, we do this. No, we don't do this. And maybe those things offer areas to discuss. What would it look like to offer this service in this way? What would it look like to reorganize our team in this way? Maybe it's not possible, but we just want you to have access to that tool, to see what we're talking about there. I do think that many programs sort of pick and choose the easier parts of the Housing First model to implement. And so when that happens, you're not going to see alignment with all of the research outcomes that would be expected, right? And that makes sense. You're not doing the model to fidelity. You're going to get some different outcomes. Okay. Let me pause here and ask whether there are questions, comments people have right now. I see some folks are kind of step away. I'm glad you're going to have access to the recording. I see a question from Mike. Any measures for advocacy to end stigmatizing homelessness for communities and politicians? This is a huge and good question, Mike. Thanks for asking this. Um, I'll share with you now that our mayor, our current mayor, is taking a pretty hardline stance in our community around substance use and encampments. And so a number of encampments in the area of our city that are heavily impacted by drug use um, are being
I'm gonna
swept.
get help, get the volume back.
Um, and so I don't know. I'm thinking out loud here, Mike. What we try and do here at Pathways is doing writing. In other words, sort of like writing advocacy type documents, having blogs, things that we can put out there in a public way to talk about what we're seeing and to talk about some of the same stuff that we're talking about here today, right? That the experience of homelessness is not a moral deficiency. In fact, it's many times a structural set of factors that are impacting people. We want that to be front and center. These people are not bad people or even any different from us in some meaningful ways, right? They simply don't have access to housing or financial stability in many of the ways that we do. So wanting to kind of center a lot of what we've been talking about in the earlier part of this training. And so we have to do a lot of networking with people that pull the levers of power to do that.
We
What else?
also, Brian, we something that came to my mind is when there's like a big city meeting on a certain topic that involves homelessness or substance use or these sweeps that Ryan keeps referencing, that's our major concern right now that we keep seeing. There will be city meetings about them that are open to the public, and our CEO or COO will send out an agency-wide email saying, like, please show up to this. Let's go in a group. The numbers matter. Even if we don't say anything, our presence being there is important as well. And there are opportunities sometimes to speak as a service provider at those meetings.
Yeah, I haven't heard as much about this recently, but I mentioned our community inclusion department. The full title of that department is actually Community Inclusion and Advocacy. And so at various times, there have been staff members on that department who facilitate
Oh,
getting
that
some of our
muted.
participants to
Hmm.
go down to the state capitol or to city council and speak about their lived experience and what it was like to come through the homelessness system, what it's like to be housed now, and I think that's really impactful to have somebody who's not a service provider talk about their own experience of the system. I see, I just want to give a shout out, Gary. I see you're like working with your audio right now. I just keep muting you so that the whole meeting is not hearing you. But I hope your audio is working for you. Yeah. Okay. I see that we're 4 minutes past the hour right now. I think it's a really good time to take a 5 minute break before we dive into our next section on benefits and challenges. So go fill up your coffee, stretch your legs. We'll come back at 9 minutes past the hour and we'll dive in for our second half here. All right. Let's talk a little bit about the benefits and challenges of using a housing first approach in our service provision. In terms of benefits, I do want to say, and I guess you've heard me say this already a little bit, but housing first is not new, right? And so it's been around a while. And as a result, there is a 30-year track record of evidence behind this model, right? And so in terms of thinking about what could services look like in my community, I like the idea of being able to kind of reference a service model that's been around and has a long track record of success, right? And not just success here in Philadelphia, but across the United States, in other places across the world. One of the big kind of outcomes that we highlight often is that there is an 85 to 90% retention rate expected in a high fidelity housing first program. You see this in the research literature. We've done a review of our program and found the same result. In other words, when folks become housed, 5 years later, 85 to 90% of those folks are going to continue to be housed. This is not what you'll see in other program models in terms of that retention rate. And so I think it's a big deal that it's not a revolving door, right? When we operate a housing first program, people are exiting homelessness and staying in homes, right? We're also going to see that it eliminates or at least decreases the need for more expensive programs, right? Thinking about things like long-term shelters and sometimes transitional housing programs, which are expensive services and which don't always have kind of an endpoint in mind that a person can hang their hat on, I guess I'll say, right? We'll also find an increase in medication compliance and treatment adherence, which I think is an interesting thing to say. At no point do we require medication compliance or treatment adherence. It's not just at the front end where we say low barriers, no, you don't have to be sober, no, you don't have to be on medication, no, you don't have to access medical care. It's also throughout the that person's experience in the program for the duration. Many of our folks are accessing those recovery supports, treatment supports, et cetera. But that's not through us compelling them or coercing them to do so, right? And in spite of that, they are adhering to treatment regimens. They are adhering to their medications, right? And so again, I'll reference to kind of Maslow's hierarchy piece of this. People want the same things that we want for them often. They don't always want them at the same times that we want them for, or like in the same order, right? And so providing that stable base of housing allows people to move these goals of theirs forward at their own pace and at their own rate, and consequently are more successful as a result. We also see a decreased hospitalization, and specifically around behavioral health hospitalization, which again is an expensive service. We see increased satisfaction, and they're attributing that to efforts around community inclusion, around family reunification, increased independence that they experience in their lives. And some of those things are not always offered by, I guess, what I would call more traditional housing programs, right? With the team approach and with the intensive level of services, we are getting to know folks really well and finding out, oh, wow, you have a sister in North Carolina that like really cares about you and wants to see you more. And sometimes we facilitated people like moving, no longer being in the program because they're moving out to another state to be with a loved one who can help them live their lives. Extreme level of success from my perspective, right? I will also say that one benefit is a quick startup time. So when we kind of compare and contrast this with maybe a congregate permanent supportive housing type facility, the zoning, the capital that you have to raise, getting the community to agree to allow you to put a permanent supportive housing structure in their neighborhood, right? These things go slowly. And so in a housing first program that is scattered site, that uses subsidies and the kind of traditional rental market, it can be pretty quick. When we first started in 2008, we were equipped to deal with one clinical team, up to 70 to 80 participants, and we're able to get housed up in several months, right? Pretty quick to move from this person's experiencing unsheltered homelessness on the street into their own unit. We also think that there is an improved kind of like, there's this community benefit that takes place, right? Improved quality of life for the folks who we're serving, as well as the folks who are their neighbors. There are not people panhandling on the street necessarily anymore when they're inside, right? There's less folks sleeping on the street. There are less kind of unmanaged symptoms of mental illness and substance use happening in public and openly. Are folks still using drugs? Are folks still experiencing substance use challenges and mental health symptoms? Yeah, but they're doing it from like a safe space for them with support in the home. We also know that housing itself has a tremendous benefit on people's health, right? When you're housed as opposed to sleeping outside, you are less likely to have new onset of illness and injury that occurs frequently while people are living on the street, right? You're going to have much better access to high quality, coordinated health and behavioral health care and other critical social services. What's the way that you're going to get that if you live on the street? Well, you're going to go to the emergency room, and you're going to go to the emergency room again, and you're going to go again and again and again. We have folks who have histories of like 40 emergency room visits in a 6-month period. The hospital hates that. They don't get paid for those services after the first one in a given month, and they feel ill-equipped to deal with it, right? And as well as not having the kind of coordinated care along the way, right? So when people are in a home, in a housing first program that has access to integrated care services, we're able to help facilitate this like long-term management of health. And then, of course, we know that being in a home promotes lifestyle behaviors that lead to good health, like going shopping for groceries and cooking meals for yourself, right? That are healthy, or that we can talk about the health effects of what you're eating, like have an open conversation about it in a harm reduction oriented way, even, right? These things are going to have lasting effects for people. Talk a little bit about cost here. When we think about some of those more expensive services that are out there, inpatient rehabs, congregate style housing, housing first tends to be cheaper on a per night basis for folks. These numbers that you're seeing are a little older. They came from a 2011 study of our program that showed that our program is simply less expensive per person than comparable programs serving the same population. So something to keep in mind, housing first can be cheaper, and it's going to be good for the individual and the community. In fact, housing first can be so much cheaper in some versions of our like service system that we're approaching managed care entities and saying, all that money that you're saving in the emergency room by having somebody housed and decreasing their emergency room visits, what if you broke off a slice of that money for us and maybe so we have like a couple of positions that are funded by the managed care organizations as like health service navigators as additional layers of support because it's that much cheaper for them to see those health care costs decrease, right? And have people's needs be met in that way. Caitlin, take us through these next couple slides. These are some slides around like the myths of housing first that I think are out there.
Yeah, this could be things that you hear people say to you in the community, or folks that just don't know a lot about housing first, and sort of the response that you can have to that. As we've said multiple times throughout this training, it's not a new radical idea. It's been around for 30 years, and there's evidence-based practice or evidence-based material that backs up the practice. It is not housing only. The biggest part about our work is the work that we do in the homes with people. I always remind new service coordinators, these are folks that either have not been housed in a very long time, they may have never had their own housing, or if they did have their own housing, they were not successful in managing all of the components and relationships that go into maintaining an apartment. So the wraparound services, meeting the participant where they're at, doing the in-home work with them is the crux of the work. The apartment is just the base to do it in. Oftentimes when people first move into a unit, the biggest work that we're doing with them is assessing their level of comfortability in the apartment. Do they know how to navigate the kitchen? Do they know trash day? Do they know where to take out the trash? Like we should never assume, we don't want to be pejorative or speak down to anyone by any means, but it's assessing where each person is at in an individualized way to help navigate where the gaps may be. Housing first is not anything goes. Our participants do experience consequences to negative actions that can sometimes happen in the form of a landlord having issues. And if someone is having an issue with the landlord where they're doing activities in the apartment or having a lot of traffic in the apartment or something that is disturbing the neighbors, our role is to help the person understand how to maintain the housing and to repair that relationship with the landlord. But sometimes there are consequences where the landlord will have had enough and that person will be evicted from the apartment. We don't drop them from the program at that point. We then help them try and maybe get rehoused, go into shelter in the meantime, figure out a solution. But it's not that that person can just be in the apartment and do whatever they want to do without any sort of direction. Housing first is not a threat to the safety of others. As Ryan said earlier, oftentimes a stigma can be someone's on the street, they're dangerous, when the reality is that people with serious mental illness are oftentimes having violent acts put upon them. When something that I have seen in a very realistic way with outreach is you rarely see violence, but sometimes what you'll see are people that think that in order to advocate for themselves, they have to speak loudly and they have to be abrasive because that is what has worked in the past. That's the only way that they have felt heard. So oftentimes if I see that happening with someone, I'll just explain, we'll use de-escalation skills to help them to know that their voice will be heard, whether or not they're yelling or not. And I also speak to people in the very beginning when everyone is very like happy, excited to be a part of the program, or even if they're just like learning about the program, I'll explain, sometimes when people feel frustrated, they'll say things they don't mean. And one of our components of the housing program is that we don't accept violence towards others, including staff or your peers, and that can include verbal threats. And I have seen oftentimes that people, when they're very, very upset, will say things like, I'm going to mess you up, I'm going to kill you, I'm going to do these things that they don't mean, but they're just so used to using those terms that when they're angry, it can come out. And so I'll speak with people in the beginning, like, if you are feeling very upset, and you say something like that, we have to take it very seriously. So please just tell me, I'm feeling very upset right now, and we'll talk through it so you don't accidentally say something that could make you not be a part of this program. So that's a way to see like a realistic kind of de-escalation of people, someone that might not know, they're not violent, but they just don't know how to manage their anger levels when feeling frustrated. Housing first is not enabling. That is something I think that can be a common like term that people throw around the community, like, oh, you're just giving them a handout. Like they don't want to work, they don't want to take care of themselves. And obviously that is not the case at all. Housing is a basic human right. And it can oftentimes mean that someone thinks that someone needs to like pay their dues, or they haven't like suffered enough to then get the reward of housing. And that can be a key for us to know that that person just does not understand the housing first model, and giving someone the basic human right of housing is not enabling. It's not an intervention that only works for some. This can be a point where if you see that someone requires a lot of supports, we work with our community. We work with doctors that understand the harm reduction approach. We work with, if we have a slight wait for an apartment to be ready, we work with our shelter providers. We work with folks that have intellectual disabilities and like what supports we can give them. Our COO recently has been trying to really implement a lot of technology in the apartments and working with providers that can provide technology to help make apartments more accessible for folks, with their consent, of course. That has helped house some people that have struggled with housing just by having more monitoring, that if a door is left open or something like that. It's also not a one size fits all approach. What makes housing first so wonderful and what can make it so challenging is that it is highly, highly individualized. We'll see in trainings and just like in our work, people will be like, well, if someone does X, Y, Z, what happens? And the answer every time is it depends. Like, well, every time we have something going on with someone, we'll have a case conference, we'll assess it on a very individualized basis. It's not just if this person, as Ryan said earlier, like goes through 3 apartments, they're no longer housed with us. It could be that they went through 3 apartments because they were experiencing domestic violence and their partner, the perpetrator of violence, kept finding them at those apartments. It could be that they had a horrible neighbor at one apartment and had to leave. So we can't really make these hard, fast rules. We assess on an individual basis. And that goes into some of the challenges that we see. As Ryan said earlier, we screen people in, we don't screen people out. And if we're having trouble screening someone in, that's when we think of all the other supports that we have that could help us bring that person in. In our case, we partner with an agency called Project Home that has a clinic on site. They can be a huge support. There's agencies, Prevention Point in Kensington will oftentimes do, and Project Home will do street wound care for our folks. So if someone isn't ready to go into a hospital to get care, we can bring providers to the streets. So to think of all the ways that we can help make things accessible to someone versus saying like, oh, they need more than what we can offer. Who are the other providers that can help us with this? The system is not always oriented to serve those with the highest needs, especially at Pathways to Housing. We are seeing the people that other systems have failed them, and to remind yourself of that and to say like, what can we do to not be another system that has failed them? I said this earlier, collaboration with non-harm reduction providers. We have a medication assisted treatment program, and something I've heard them say a lot is it can be the luck of the draw with what sort of doctor our folks get. A doctor that understands harm reduction, a nurse that understands harm reduction can make a huge difference to somebody with opiate use disorder staying in a hospital long-term to get medical care without going through withdrawal. And working with those providers, we do see sometimes, one of the MAT workers told me recently that a nurse just didn't understand, and they said, he's not, it's not my fault he's going through withdrawal, to that participant, to which that person then had to rope in other hospital staff members to be like, he is going to leave the hospital and not get care for his infected wounds unless someone helps him with his withdrawal symptoms. So there's a huge advocacy piece with that as well. Consumer choice can mean unpredictability. It's not linear. Someone will make a choice one day and it could change the next. And our job is to meet them where they're at, have conversations, understand what's going on, and then assess how we can best support. It only sounds easy. Can be something that we hear pretty often. Working with people, once again, is individualized. It takes a tremendous amount of patience, checking our own biases, checking what, like Ryan said earlier, what we want for the participant versus what they want. And that can be seen with other agency providers too. There's a city outreach worker that I work with sometimes that she will oftentimes want housing for the participant more than the participant wants it. It's not that that person doesn't want housing, it's that there are several steps that they need to get there. And that person will call me and be like, why haven't you housed them yet? They told me they want housing. And I'm like, yes, I understand. And we are working, and it's working with that provider to understand that, yes, we are housing this person, but there's a few steps that that individual person needs first and have expressed that they needed, which is they can't always articulate. Oftentimes someone living on the street will say, yes, I want housing, but then we have to infer and work with the steps that will help them get there.
Thanks, Caitlin, for sharing that. I think it's fun to go through those like myths and challenges because they're real. And it's often a pretty good, that gives us an understanding of like how connected or understanding of housing first people are when they sort of parrot some of those myths. Want to go through this section a little bit quickly, but this is our effort to kind of compare what we've been talking about so far and the spirit of what we've been talking about so far to what we think represent more traditional models, right? So the first thing I want to show you is this flow chart. Not asking you to memorize this. This is kind of an older chart from the city of Philadelphia. And it's the way that folks navigate our shelter system, right? And I show you this to show you the way, from my perspective, I think a shelter system should be a pretty low barrier process. If you're not housed, you go to the shelter, you step inside, you sleep. And of course, it's much more complicated than that, especially here in Philadelphia, where we have this kind of like centralized intake process. Do you have your medications with you? No. Denied shelter or given short POS must get medications regardless of insurance status, right? That's a barrier. That's a barrier to sleeping inside that night, right? And so when shelters are scattered around town, when you're not sure where to go, whether you're meeting all the qualifications or the eligibility for this thing, it might seem preferable to stay outside, right? I'd rather live in a tent with my belongings than navigate the logistics of all of that, the safety of all of that, the stigma that I have faced along the way in past experiences. So I think, creating a coordinated shelter system that kind of operates from the principles of housing first does make a lot of sense. Removing barriers, focusing on the needs of the person in front of us or the family in front of us is going to be key. And of course, what we see in the kind of homelessness services continuum are things like the following. You've got your shelters, your safe havens and cafes that are more temporary. You've got your longer term drug and alcohol or mental health treatment type facilities. We even see a number of like residential facilities specifically tailored to specific needs. Maybe it's a residential facility for people who have experienced HIV or folks who are formerly drug users, right? Kind of these like really specific populations of people. We've also, of course, got local housing authorities, right? I don't know about your area, but our wait list to get on the housing authority kind of list for a subsidy, I think is probably more than 10 years long. It's not open very frequently to even put your name on. And so when it opens, it fills up really quickly. And then it's, years and years and years of waiting. Skilled nursing facilities may be a place that um, are an access point for people experiencing homelessness, and things like medical respite. Um, I think key here is that many of these types of programs have sort of specific rules somebody has to follow to become eligible, to remain eligible, um, you know, to be engaged in some sort of treatment. Usually folks have to maintain sobriety in a lot of these types of settings or take medication for psychiatric symptoms. And of course, that wait list that I mentioned is a huge barrier, right? From our perspective, or from a housing first perspective, and this is not terminology that I see usually outside of a housing first perspective, but this linear residential treatment term is a term that shows up in the Pathways to Housing manual. And it's kind of the idea that our homeless services, our housing services, follow the therapeutic milieu model, or what you might have heard called like a level system. I've sometimes done this training with a former colleague who lived in a boarding school, and he kind of makes that analogy, right? Like when you're on good behavior, more becomes, it opens up more possibilities for housing, right? And so people kind of work their way up the system. I start in a shelter, I work with my case manager there. Maybe I arrive in some version of temporary housing. Maybe eventually I can move up into a transitional housing. And at the end of the rainbow, perhaps there's permanent housing available, right? And so people will work their way all the way through the range of supports and services, sometimes even arriving in independent or shared apartments or mixed use buildings. This level system, of course, that's based on like the psychiatric hospital model, that earning of privileges model. The thing we want to say about it is it's not, in fact, empirically based, right? Like there's no kind of research literature that says like this level system approach to people earning their housing is an effective way to help people exit homelessness. And so kind of comparing it to maybe even like a congregate permanent supportive housing program, thinking about like those buildings. We have a bunch of these from a provider that works here in Philly that have these huge, beautiful buildings, or I'll say that they're beautiful. They're modern. They're kind of ugly. Um, these huge buildings that house people, permanent housing, right? Often have a set of services that come with that, right? Like maybe on the first floor, there's social services offices and case managers can meet with you there on site, right? This milieu model in those types of congregate care settings, one way of thinking about it is that housing is sort of offered as a reward for compliance with treatment. Unfortunately, the thing that led people to needing that level of services are their co-occurring disorders, their mental health and substance use challenges, right? And so sometimes people will run afoul of the program rules, or not be able to sort of cut it in those programs. And what ends up happening is they lose that housing, and consequently they lose the services that are attached to that housing. And so what we're doing here is, in one way of thinking of it, is that we're punishing folks for displaying symptoms of the thing that led them there in the first place. I guess our question here is that an ethical approach, right? Like this reward system and this punishment system. If your perspective is that housing is a basic human right, I don't think it makes sense. And from our perspective, this is one of the reasons why chronic homelessness exists, right? People who have not been able to be successful in these more rules-oriented programs, that can kind of pull the rug out from people, right? This represents a lot of our population who have tried and failed in multiple programs, and they're at the last stop, basically, right? So to kind of put a bow on this comparison, we've got the linear residential treatment on the left, housing first on the right. I guess I'm making some generalizations, right? I'm trying to pitch a case to you here, and I am very biased because I'm a housing first provider. But I think LRT models really kind of have this assumption that we know best for people, right? And we still treat homelessness through this kind of morality lens. If I can get you to behave in a certain way, come in at curfew and not have drugs on site and things like that, you'll be better off, right? And then you'll be successful. And of course, folks have to demonstrate those desirable behaviors to earn their housing. Around the clock staff supervision is a component there. Folks don't have as much choice and self-determination. The transitional housing option that we have is what we have in the end, right? And of course, housing is going to depend on availability. As opposed to a housing first model, we've talked about the fact that it's evidence-based, that we try and put the client forward as the expert of their own lives and of their own experience. I think when Caitlin talks about this idea that like she'll do outreach with folks and they, Caitlin has an apartment ready for somebody, let's say, or maybe in a couple of weeks there will be an apartment ready and say, hey, do you want to come inside? And folks are like, no, I want to work on this, this, and this. They're the expert of their lives and we will follow them down that path, knowing that at the end of that, when they're ready, when they've developed the readiness and we've supported them along the way and developed that relationship, they're going to come inside, right? Housing is a human right, that concept again. Again, providing folks with a really high level of support so they can be successful in the community. We talk about home visits. Caitlin mentioned the twice a month thing. That's kind of where we're at right now. High Fidelity Housing First actually asks for once a week visits in the home. That's a pretty high level of support. For us, we're pretty flexible, though. When people are first moving in, we might see them 3 times that first week, or 4 times, or every day. What is necessary to help this person be successful? Are they always going to need 4 times a week visits? Probably not. But right now, they might. When they're in crisis, they might, right? And so having the flexibility to kind of meet people where they're at. Offering choices at every stage. And then because of the way I said this a bit earlier, this like scattered site way that we use open market rentals, move-ins and relocations can be much quicker than like these building and congregate type settings. All right. Caitlin, I'm going to kick it over to you to talk a little bit about what it looks like to initiate services and to continue to like lower barriers through that process.
Got it. Thank you. So we're going to talk about the referral process, outreach, and engagement, which is my area that I work in on a day-to-day basis. So for Pathways to Housing PA and for most housing first models, those that qualify are adults that are 18 plus. We don't have an age cap. And they must be okay with living as a single adult. Plenty of our folks do have partners, children, family members, close friends, but those people cannot live with them. They can visit, they cannot spend the night. So I always make that very clear in the beginning. We want you to have a full life. We want you to invite people to your apartment as you would in any circumstance, but you must live there alone. And then another qualifier is to have a diagnosis of a serious mental illness and or a substance use disorder. Oftentimes we do have folks with co-occurring disorders, and we work with our psychiatry team to determine which of the teams is best suited for them. We have teams that serve folks with a primary mental health diagnosis. We have 2 teams that serve folks with opiate use disorder as their primary diagnosis. And then we have 1 team that serves folks with any substance use disorder as their primary diagnosis. And they must be experiencing chronic homelessness. We do have certain slots where we can allow folks in that might not have this documented. As I said earlier, we work sometimes with other case managers, with the participant themselves, to give an oral history of their homeless history. We have certainly seen that some populations do not have documented homelessness, especially. Oftentimes we saw maybe like a year ago, our data showed us that the transgender population was underrepresented in our agency, and that is because that population oftentimes does not have documented homelessness because of not feeling safe in the shelter system, not feeling safe interacting with certain workers. And so we created slots for folks that have not had the documented history that others have. People that can be prioritized: if someone has a chronic acute health condition, we may house that person quicker than someone that is maybe staying in a shelter with stable health. If someone is in the criminal justice system and they're being released from prison or they're being released from a treatment program, we don't want that person to then go back to the street. That can create so much instability. So we try and create a direct pipeline to either our permanent housing, or we do have some temporary units that we use for folks when an apartment might not be ready right then, but they can at least be in a temporary apartment. And if there's someone that has an issue that disqualifies them from other housing programs, that is someone that we will take into our program oftentimes. The model can work for any population. There is not we serve everyone, and we've never said like, it does not work for this population. It works on an individualized basis, and we really take it from that approach.
Wanted to mention too, Caitlin, as you were talking about this idea that serious mental illness or substance use disorders, and that does require like some verification with psychiatrists. That I think could represent a challenge, like a barrier for folks, right? And so I think we've seen some unique and creative ways that our psychiatrist has tried to like meet that need, including sometimes being able to literally physically go out and see people outside, which is not something I've seen in other agencies that I've worked at, right? Where psychiatrists are usually kind of holed up in their office and people come to them, or even like some informal phone calls or iPad type communications. Are there other things you've seen there, Caitlin, as ways to kind of like reduce those barriers?
Absolutely. And that's something that, especially for folks that might be experiencing paranoia, the mental health psychiatry piece can spark that. I say to people in the beginning, we need to have a psych eval dated within the past 6 months. So if you have one from another provider that's within the past 6 months, we can use it. If you prefer to see your own provider in the community, please do. And that can sometimes reduce some of the anxiety of like, you must see our provider. And then our providers are an option as well. I have found that a phone call psych eval, we know it's a psych eval, but that can help someone feel comfortable too, that they won't be pressured to keep meeting with the psychiatrist if they don't wish to. So we do present it in all different ways. We had someone recently that one of our psychiatrists, as Ryan said, went out on the street to meet with him because this person, it was challenging for him to come into our office. His comprehension of what was being asked of him might not have been super high. And the most accessible way was for the psychiatrist to go into the field. And he did not sit there and ask him the same questions that he would ask somebody that was higher functioning for a psych eval. So we never want that to be the barrier. Also, there's paperwork that I fill out with people in the beginning, and it can be filled out to any level of ability. Just because someone can't answer a question about their history of incarceration or their history of anything does not disqualify them. I just fill it out based off of what they tell me, and if they say I don't know, then that is the answer. So a lot of flexibility, once again, screening people in, not screening them out. So the way that in Philadelphia it works is we get our referrals usually from city outreach workers. There's various agencies around the city, including the city of Philadelphia itself, the Department of Behavioral Health, that is on the street meeting with folks, and they identify who has the highest need for housing at that time. And we receive our referrals directly from the Department of Behavioral Health. And lately, we've been also getting them from the Office of Homeless Services. So our model is that we don't just go out on the street and take referrals ourselves directly, but we get them from other providers who are working closely with people on the street and telling us who has the need at the time and who they think would be most appropriate for our program versus other city agencies. We oftentimes see high utilizers of drop-in centers and shelters, hospital emergency rooms, psychiatric hospitals, mental health court. Sometimes when we're looking for new referrals, I'll work with the Department of Behavioral Health to check who the highest utilizers at the hospitals are right now, and to advocate for those folks to come to us.
Yeah, and that's the way we do it. We're kind of trying to, we talk about pathways a lot in this training because we do high fidelity housing first, but we recognize that other communities may approach this referral process differently. It's the way that they have sort of deployed pathways in our continuum of care. But we recognize that there are other ways to sort of receive referrals. Sometimes people receive referrals directly in a housing first program, other times not. This is simply the way we do it. But that key of like the high utilizers, that's going to be a pretty big indicator of like who is not being well served by the system as it currently exists. And in addition to that, like not serving that individual's needs, it's going to be quite costly to see them use those services over and over again. Let's get those folks a home and start working on like higher goals for them.
And I will say our referral process is ever evolving, and that's normal too, of like meeting the city's needs, meeting our needs. when I meet with someone in the beginning, I try and make the program expectations clear, but that also they can a person can choose to modify or refuse services at any time. Just because someone says they want support with I don't know, cleaning their apartment today, and then I show up tomorrow and they're like, you know what, I need a day to myself. We respect that. We meet people where they're at. If they don't want what you're offering, offer what they do want. Okay, I'm here today. What would be helpful? Do you need to go to the grocery store? Like, have you been in touch with another provider that you're in touch with? Just meeting someone where they're at and not saying, okay, you don't want me today, and just like leaving. I've seen that with newer service coordinators sometimes that are still learning the role. If they show up to bring a participant to a scheduled doctor's appointment and the person says, no, I'm not going today, I changed my mind, they just say, okay, and like leave. And I'm like, wait, no, there's more work that can be done there that day, even if they don't want to go to the doctor. And the work is not trying to convince them to go to the doctor necessarily. The hard kind of the things that I make it clear that we have to have someone be on board with is to sign and adhere to a standard lease, agree to receive home visits and the rent contribution. And I make that very clear in the beginning to set expectations. And usually when folks hear that, like day one, first meeting us when they're ready to talk about housing, most people can understand that. It's not to say that there aren't continued conversations around it as well. Something to note is that if someone refuses to sign paperwork, that doesn't mean that they can't be in our program. I oftentimes see people refusing to sign releases or refusing to sign other things due to paranoia, due to not quite trusting us yet, due to relationship building. Fine. That's okay. We don't want that to be a barrier. We don't want someone's mental health symptoms to potentially, or just their desires to be a reason for them not to receive housing.
I just want to like put a finer point on this home visits piece because the model, as I mentioned earlier, does ask for kind of a once weekly visit. That's what High Fidelity Housing First suggests. We're currently meeting the expectations of our funder, which are twice a month. So in that way, we're not upholding High Fidelity Housing First. But again, having the flexibility to meet that frequently is necessary. And also the expectation, as Caitlin mentioned with the participant, that like we are doing the work of Housing First happens in the home, in a home visit. Well, when it's not happening on the street during outreach. And so kind of making that a cultural component of the program as well as this expectation is pretty critical on the front end. And we often hear from other providers that say, how do you get them to let you in the door? I'm like, that's the whole work, right? Like that's the whole thing is trying to figure that question out. And setting that expectation early is pretty critical. And then I think to Caitlin's point around assertiveness, not just like turning around and saying, oh, well, I'll write him a letter. You know, I think there's like a ton of work and creativity to bring to bear on making sure that those home visits are happening.
And a way to phrase it too is I say, like, for every single person in this program, we come into your apartment, we walk around, we check on the apartment, we ask you how you're doing. We won't make you do anything that you know, if you're saying that you don't want to do anything other than us just showing up that day to walk around, we will respect that, but we must come in. And I make it very clear that we come in and walk around piece, because for some folks, it can easily be interpreted as you're only doing this for me, or you think I have a problem and that's why you're coming in. So to make it clear that we will always come in, we will always walk around. It is a part of our responsibility within the program. So that expectation is set. Another large piece of the work that we do with folks is treatment planning. And once again, this can look very different depending on who the person is that you're working with. Some folks will be like, I know my goals, here they are, let's talk about them. Other folks will be like, I have absolutely no clue what my goals are. And oftentimes that's when we just talk to them about like, maybe your goal is to just be in an apartment. Maybe your goal is to feel at peace. Maybe your goal is to not worry where you're going to sleep each night. And the language matters too. For some participants, you can use the word goal. For some people, I don't recommend using the word goal. I just recommend talking to them about like, what are your needs right now? That the word goal can make them, we never want people to think that we have an agenda or that we are trying to place too much structure on someone that would spark fear or hesitation. That being said, we do personal goal plans. We do have various assessments that we do with participants. to help promote buy-in, to clearly address what we will do. And I explain to the participants oftentimes too, like, we're stating to everyone that you want to be housed, if that is your goal, or that you want to become more involved in your community, whatever their goal is, so that everyone is clear, the whole team that you're working with is clear that this is the focus of like what you want from us at this exact time. And then we clearly outline the role of the individual and the staff and the community. Participants don't want to be saved by us. That's something that can come up in this work accidentally sometimes, and without us realizing that we're putting, once again, like our desires or what the potential that we see in someone, we're like trying to nudge them quicker than they may want to move themselves. It is their life, it is their goals. We are there simply to support that, not to create those goals for them. We don't do things for people, we do them with them. A perfect example of that can be exactly Heather, empowerment. If someone struggles to navigate a grocery store on their own, but that they want to go grocery shopping, it could be very easy. And I've seen this happen on teams where the service coordinator is like, well, I'm just going to the store for them because it's hard for them. No, we go to the store, have the person go to the store with you if they are comfortable with that. There was a participant on a team I was on that she was a woman who physically moved slowly, and it took her a while to process things, but she loved grocery shopping. And we would take her to the store, and it would literally be a 5-hour activity to go grocery shopping with her. But it was beneficial. She was able to be in the community. She was able to pick out her own food. She was able to feel like she had the ability to do that. It would have been hard for her to do on her own, but with another person there, yes, it took a long time. But once we learned that about her, we just made the time in the schedule to do that, so she didn't have that taken away from her. And I think someone even suggested to her once, like, I'll just go for you, which they should not have suggested. And she was irritated, as she should have been. She was like, no, I can do it. I just need a little bit of help. So we're there to do things with folks, not for them. And also to, the hope is with empowerment, as it always is. Anyone that works in this field for a long time knows this. That the hope is that the person may eventually be able to do that completely on their own. Maybe they won't. Maybe we'll always be there with them, and that's okay too. But never to do it for them. The key question at every stage of the process is, how can I help? Literally every home visit, that's what you should be asking. The biggest mistake that folks can make is going into a home visit with their own agenda. It's like a joke that if you go in saying like, we're going to do X, Y, and Z today, like you will not be doing that. There's no one, like it's always the opposite. So to go in and ask the person what they're looking for that day, if they struggle to identify what they're looking for, then that's when you can kind of give gentle observations. Oh, I noticed you haven't taken out the trash in a little bit. Can we do this together? I noticed that your fridge is empty. Should we maybe meal plan a little bit today? And to give those gentle suggestions based off of your observations, but never to say we are doing this, or you must do this unless a life is in danger. It should always be meeting the person where they're at.
All right, we're really getting quite close to the end. We have only 6 minutes left together, so I want to go through these quickly in case there are some questions that we can answer from folks. So I'll just say, and we have training on, whole trainings and even training series that we put together on some of these topics here that you see on the screen. But Housing First incorporates other evidence-based practices as a part of it, right? Including the practice of harm reduction. We're heavy proponents of harm reduction and make use of it every single day for our drug users. And we also apply concepts of of harm reduction to folks who are engaged in other risky behaviors besides the use of drugs, including maybe, for example, folks who are engaged in sex work as a primary survival economy, or folks who choose not to take mental health medication, right? Maybe have a diagnosed mental health disorder and are not wanting to engage with a psychiatrist or a therapist. What does it look like to help that person stay housed and maintain their independence despite that choice that they're making? So motivational interviewing is also a key evidence-based practice that we make use of. It's a part of the Housing First model. I'm sure many of folks here are familiar with motivational interviewing, but trying to kind of recognize the gap that can exist between what people's stated goals and aims are and what their behavior is currently, And how can we bring those two things closer together in service of helping them maintain their tenancy? And then lastly, I think we've talked quite a bit about the experiences that many folks have had prior to coming to our program, either system-oriented experiences of loss and failure, or ones that are not related to the system of trauma that people have experienced. So kind of recognizing and realizing the widespread impact of trauma and bringing that into our services so that we're not re-traumatizing people, so that we're responsive to people's triggers and needs. I think Caitlin's example of sometimes folks, kind of the way that they've had to meet their needs is being loud and abrasive and sometimes making threats. That's been the way that's been successful for them so far. Maybe that's not the way that we'll continue to meet our needs moving forward, but we can recognize where that's coming from and be supportive of people still as they make that transition into like the next chapter of their life. So here's some key takeaways that I wanted to hit you with, and then I'll stop talking. We'll shut it up and let you talk to us a little bit if we can. Homelessness and co-occurring disorders, we've tried to make this point several times, do not stem from individual moral failings. Often we're seeing a gap in kind of structural or systemic factors and wanting to kind of be cognizant of the basic humanity and dignity of the folks in front of us and the need for housing to sort of support people as they move up that hierarchy of needs. We think Housing First is a proven and measurable solution. We're doing it every day. There's somebody in my private messages right now in this meeting saying, how can we refer people to you? And so I want to make this point to everybody. We're not talking about pathways here today to get you to think that we're so great. We're talking about pathways as an example of what Housing First can look like. And our effort is to help other communities implement this model when and how we can. So wanting to share Housing First, not share pathways, if that makes sense. Housing First is highly individualized, which can be frustrating from the provider perspective. And yet that's so important. Having people make choices that are right for them, having people have self-determination in their own lives is incredibly healing, especially for people who have experienced trauma. And so the individualization is a key part of the model. Often a Housing First program is going to serve folks who are not housing ready or said to be not housing ready by other folks in the housing system. And we think everybody's ready for housing. What it's going to take to help them be independent in that housing is going to vary. But we want people to have homes, right? And then we're basically seeking to meet people's needs. We'll identify the other goals and appropriate supports along the way. And we think that first basic need is a roof over their head. That's our spiel, folks. That's the end of our content today. There are only 2 minutes left on this meeting, but I am happy to kind of stay around for a few minutes if folks do have questions that they want to ask. Happy to accept that. And so we'll let people kind of raise their hands or type things into the chat, and we'll try and answer some questions for a few moments. As I said, we will be getting some materials out to you over email in the next couple of hours, actually. Lastly, I have dropped a link to the course evaluation in the chat. We would be so thrilled if you would do us the honor of filling out that evaluation and let us know what you thought of the training. All right, I'll stop talking. What questions do you have? Seeing a lot of thank yous in the chat. Thank you so much for being here and engaging with us. Mike has a question. What's your take on corporations buying large percentage of SFH now, and how does it affect your Housing First? Apologies, Mike. I'm not recognizing the SFH acronym. Can you say what that is? Single family homes. I think I could quickly get on a political soapbox here, Mike. In general, I will say that corporations owning something that I perceive as a basic human right is not going to be supportive of our society in the long run. I think it's going to continue to raise housing costs when you have a basic need commodified that way. The way that it affects Housing First, I think one of the things that we see is we have access to HUD vouchers, right? HUD subsidies to house people. And those are pinned to a fair market rate, right? And so we can only pay so much for rent for people. As a community begins to get gentrified and developed and corporations own more of larger percentages of it, it's going to raise housing costs and it's going to bring some of those neighborhoods out of reach for us as a Housing First program. So I think that is one challenge that we see. We are not frequently in single family homes, though. Often our folks are in apartment buildings or like row homes that have been converted to 3 apartments and things like that. So I think there is this like larger effect, Mike, but directly a little bit less, if that makes sense. Good question. Thank you. Are there other questions folks have? All right. I see there's one person I'm looking at on my screen that is typing. I wonder if they're typing a question. So I'm gonna hang tight for a second. If you need to head to your next meeting, thank you so much for spending this time with us, and look out in your inbox for our follow-up materials.
Everyone.
Thank you.
Thanks so much. Take care.
Thank you so much. Have a wonderful day.
Likewise. Happy Monday. I see your chat there, Gary. One thing I see affecting the market is the temporary vacation rentals, a lot of them illegally, taking a lot of homes off the market and unavailable. I'm in agreement with you, Gary. Here in Philadelphia, I just learned this weekend, but it's been around for a little while. There are some regulations around which properties can be allotted to like Airbnbs, and you have to have like a special permit that's really only possible to get if you're like legitimately a hotel. I think that's a good thing. I think it has in addition to the effect on the market, Gary, this other effect that it has is an effect on like the neighbors themselves, because they don't know the people who are coming in on a week by week basis. And if there are problems there, um, it can feel like a neighbor, a community doesn't have much recourse, right? They'll talk to a property manager who may live out of state, for example, or things like that. And so I agree that it's a problem. I also think, kind of related to my earlier comments, that it kind of contributes to this like growing problem of the commodification of the market, right? Commodified housing, in my view, is not a positive thing. If we kind of think of housing as like a basic human right and need. So I get it. I get that people are like finding a way to make their lives better by having access to rental income. And yet when you think about the folks who simply don't have access to any housing, it's a hard sell for me. So I'm in agreement there with you about that challenge. All right, folks, I'm going to go ahead and stop our recording. Thank you so much for spending this time with us. Feel free to reach out over email, and feel free to put any comments or questions that you have in the course evaluation. Thank you so much for being here with us.